used to. Good evening and welcome to the Aquatarium. I'm Thomas Harder. I'm the Executive Director here at the Aquatarium, and we are so proud and honored to host Session 4 of MEDtalks, Breathe Easy, Live Healthy. So before we begin, we should acknowledge that we do gather on the traditional lands and waters of the Anishinaabe, I did that wrong and I knew I would, Anishinaabe, apologies, and Haudenosaunee peoples along the St. Lawrence River. This place of meeting and sharing for many indigenous natures for many, many years. We recognize their enduring presence and stewardship, and we commit to the continued learning and reconciliation. As many indigenous peoples have said to me, when we explore a river, we are really exploring our own humanity and our health. Clean air, water, resilient shorelines, and thriving ecosystems not only influence the quality of life in our community, but also our health and well-being. Again, we are excited to host MEDtalks, linking our hands-on learning facility here at the Aquatarium with the expert health and knowledge from our folks right at our own community hospital. It's always our goal at the Aquatarium that when you leave as a guest, you're not only inspired, but equipped with habits and insights that make everyday life better for yourself and for the place that you share. And this partnership with the hospital is an integral part of that goal. Thanks again to the Brockville General Hospital and the Brockville District Hospital Foundation for bringing this community learning series to life. And with that, it is my pleasure to introduce my friend and colleague, Trish Biot, from the she is the Executive Director of the Brockville and District Hospital Foundation.
Thanks, Thomas. I appreciate it. For those who don't know me, I'm Trish Biot, Executive Director of the Brockville and District Hospital Foundation. So working very closely with the hospital to raise funds for much needed equipment, programs in the hospital. So I worked with Thomas many years ago to get this facility up and running and fundraising for that. And so I know it very well, a little bit too much about otter poop and all that stuff that you ever want to know, but it's a great venue, so we appreciate the Aquatarium partnering with us as well. This is MEDtalks. If this is your first MEDtalks, welcome. If it's not, welcome back. I'm hoping you're going to enjoy this session. The purpose of MEDtalks is really just to connect the community with the hospital, with our healthcare professionals, and bringing information that's going to be valuable to you. There's no cost to the event. It's not a fundraising event. It's just an event to bring Brockville General Hospital and the experts we have there and connected with the hospital to the community, and to really give you something that is going to help you in the long run. So today, as Thomas said, it's Breathe Easy, Live Healthy, and I'm going to welcome up Julie Caffin, who's the President and CEO of the hospital, and she'll introduce our speaker.
Thank you. So if the name Gerald Evans sounds familiar, it's because he's somewhat of a big deal. Dr. Evans has been on the radio, he's appeared on television, including national networks such as CBC and Global. He has a big social media presence where you can find him offering helpful information as he shares his expertise on a variety of infectious disease topics. During the COVID pandemic, we relied heavily on Dr. Evans for his expertise. We felt informed, supported, and reassured during a very difficult time. Dr. Evans continues to support our teams and is featured in our monthly Hot Topics, which are sessions he provides us with the latest trends in infectious diseases and answers questions from our staff and physicians. So in addition to supporting Brockville General, Dr. Evans is the immediate past chair of the Division of Infectious Diseases and a professor in the departments of medicine, biomedical and molecular sciences, and pathology and molecular medicine at Queen's University, and an attending physician in infectious diseases at Kingston Health Science Center, where he has been medical director of infection prevention and control since 2011. He is a former president of the Association for Medical Microbiology and Infectious Disease, the Specialty Society for Infectious Disease Physicians and Medical Microbiologists in Canada, where he is also a fellow of the society. He was recently elected as a fellow of the Infectious Disease Society of America. He also serves as clinical lead and chair of the Infectious Disease Advisory Committee for Ontario. He is the current editor-in-chief of the Journal of the Association of Microbiology and Infectious Disease Canada, affectionately known as JAMI. So would you please join me in welcoming Dr. Gerald Evans.
But thank you, and thank you very much, Julie, for that introduction. I sound so interesting, but I'm really not. Some of the people I work with are right back here, and they'll go, yeah, no, he's not that interesting. But again, I really want to thank the organizers for inviting me to come and talk about one of my favorite little subjects, which I think I was always interested in before COVID came along. I'm considered sort of one of Canada's influenza experts. And we're going to talk a little bit about influenza tonight. But I think the COVID-19 pandemic really made everybody suddenly recognize the whole importance of viral respiratory tract infections and their impact. Because how many of you have ever gone to, maybe you see your own physician or emergency department and you're feeling really unwell and you know, you've really thought about not necessarily going to the doctor's office, but you're so sick, and then they check you out and everything else, and then they'll say to you, don't worry. It's just a virus. I'm going to tell you how to worry when it's just a virus. Sorry, guys, I'm just going to grab this.
You're doing great.
So, oh, is that that weird picture of me? Oh, yeah. Though the only thing is I got this picture taken because all the other pictures, I really like them because I was like 15, 20 years younger. I had dark hair. This clearly shows the gray hair is there. So. But anyways, yeah, so we're going to talk a little bit about this. I always have to put this on a slide in case my early dementia makes me forget who I am. So the interesting thing that people don't know is there's lots of viruses that cause respiratory tract in humans. And this is just a sort of a list of them. And this is just listing them as groups, because as you can see, there's over 100 types of rhinoviruses, there's 4 types of parainfluenza virus, 9 different types of adenoviruses. Fortunately, some of the other ones, like metapneumovirus, is just one virus. But human coronaviruses, of which SARS-CoV-2 is now one of them, but there's a whole bunch of other ones who go by these really catchy names. OC43, 229E, HKU1. Like, no wonder nobody recognizes them. Only a goofy ID doctor would remember all those crazy names. And then, of course, respiratory syncytial virus, or affectionately known as RSV, and influenza virus. And just underneath there, so just so you know, the common cold, which I put up there so everybody understands, in the medical jargon, it's acute nasopharyngitis. So it's an inflammation in the back of your nose and in your back of your throat. And it's very much confined to that. And we're going to talk very quickly about rhinoviruses, just simply because rhinoviruses are the actually most common cause of respiratory tract infections. But this is the little smorgasbord of, I think I said that right, any Swedish people in the audience? Smorgasbord. This is what you're looking at. And they can produce very mild things like the cold, but they can produce very seriously nasty things like pneumonia, and even things like laryngotracheobronchitis, aka the croup. So, too fast. So just an important point to remember, and you all know this. This is an age graph with the youngest on the left-hand side and older people to the right. And this is the illness frequency of viral RTIs annually. And all of the burden is really carried when you're young. And the reason for that is you're basically hanging out with other kids. Kids don't necessarily wash their hands, they share lots of stuff, and you're just picking up things all the time when you're at school. In fact, right now, we're in the midst of the classic peak period for rhinovirus infections. And it always happens because everybody's back at school, whether it's elementary school, high school, or universities and colleges and stuff like that. So that's just a reminder that it's really a young people thing. This is one of the really cool things that everybody always asks me about, like, well, how come you get these things sort of during, as we would say here in the Northern Hemisphere, winter, but you don't see them much in the summer? And there's actually some fairly good science now that's come out to explain it. But you can see here that the big bad guys, the human coronavirus, now SARS-CoV-2, influenza and RSV are very seasonal. The other ones show some degree of seasonality, but I think this laser might work. No, it doesn't. But the rhinoviruses, as you can see, peak in September and October, where that dark orange color that's right there. And then some viruses, actually different types of them, like parainfluenza virus, peaks and goes in summer and spring and fall, and it's all over the place. But that seasonality for some of the big bad viruses is really important. Ooh. Now, I'm going to show you some local data. Oh, come on, you can do it. I think it's freaking out. It's skipping over the other one. Let me just go back. There we go. So this is actually a graph that shows you that this is southeastern Ontario. This is where we live. And the only thing I'm going to tell you about this is that this is a little bit weird because SARS-CoV-2 COVID-19 ended up really messing around with the other viruses. But you can see through 2023, 2024, look at the blue. The blue is the enteroviruses, or the rhinoviruses in this case. Rhinovirus is a kind of enterovirus, and it always peaks in the fall, again, when kids come back. You can see in red is parainfluenza viruses, which actually have a tendency sometimes to pop up, unfortunately, in the spring and into the summer. And then the other one, OC43, the yellow part, that's the human coronavirus. And then human metapneumovirus is in green. This got messed up because, and I'm going to show you a different slide in a few minutes, because when SARS-CoV-2 came along, remember the entire population of the globe was susceptible to SARS-CoV-2. Whereas all of us in this room have had influenza, rhinoviruses, parainfluenza, all of those other ones. We've all had them at some point. So when SARS-CoV-2 came in, it just basically shut down all the other viruses. Some of you may recall that the first 2 years of the COVID-19 pandemic, we didn't see any influenza. In fact, it led to the extinction of a specific lineage of influenza B, and it doesn't exist anymore. So there were two lineages, the Yamagata lineage and the Victoria lineage. And what happened is the Yamagata lineage has disappeared and it's never come back. So viruses have this effect of what's called viral interference. If you have one virus, the other viruses can't come at you because there's all kinds of mechanisms that your immune system activates to keep the other viruses at bay. And when they dominate, like SARS-CoV-2 did during the pandemic, it just shut down all the other viruses. So it's a bit of a funny graph because it's not really what we were seeing prior to 2020. And then this is the big bad guys. Green is RSV, blue is influenza, and red is COVID. And you can see that COVID had this tendency at least to be peaking in the winter season. That's dropped off a bit. And into 2025, we haven't really seen a lot of COVID activity since really late February, early March. This has been the quietest period for SARS-CoV-2 since the pandemic started. And we're now seeing a rise, and I'm going to go into that in a little bit when we talk about COVID. You can see last year's flu, it's so big it went off the graph. I made sure that the units of both graphs were the same so you'd be able to compare it. But it actually went above 20%. And we had a bad flu season last year, and that was probably the effect of the fact that SARS, or COVID-19, dropped off. One of the most fascinating things is the only virus that really knocks out COVID is influenza. So it's kind of like, you know, somebody offering you, like, I'm going to offer you two bad things. Which one would you like, influenza or COVID? And basically, if you get one, you won't get the other one, sort of idea. So, but anyways, that's the kind of influence we see. So the seasonality of viruses are actually related to the three things you can see on the right-hand side. Changes in the environment. So in winter here in the temperate part, especially here in Canada, it's cold and dry. There's changes in human physiology that are actually induced by those temperature changes, and then there's changes in human behavior. I mean, it's not much fun to be outside, well, unless you're a ski buff or something else, like at -20, -30, hanging out outside doing stuff. And even if you did, the air is so cold and dry that it's producing adverse effects. Whereas in summer, most of us are outside, we're not in indoor spaces. A reminder that when you look at these viruses, there's three mechanisms that spread them: direct contact, so just being right with somebody and having them spread it to you. Fomite transmission is really important, especially when we talk about rhinoviruses, because that's how rhinos spread. They spread through contamination of the environment. So somebody, you know, you're out somewhere, the guy before you's got a rhinovirus infection, and he's walking around or whatever because he doesn't feel that sick. Rhinoviruses don't make you feel like sick. And he sneezed, and then he grabbed a door handle and opened the door and went in. You come by 20 minutes later, and you grab the same door handle, and right at that time, you got something in your eye, so you went like this, and then you basically inoculated it into your respiratory tract. So that's fomite transmission. And then inhalation. So inhalation occurs because even as I'm talking here, I'm pushing out droplets as well as aerosols, and short-range aerosols in particular, if you're in contact with me, will result in transmission. So the big thing I'm going to synthesize this down for you because this is just breaking down some of the things that I just talked about, about seasonality. The number one thing we now know is humidity. Humid air is really important to maintaining health, both of your respiratory epithelium and all the other things, and it has an impact on the stability of viruses. Here's the table I'm going to show you. So if you look at the lower thing in red there, which is winter, humidity is low, even indoor relative humidity, and therefore respiratory viruses are highly stable. There's a lot of them in droplet nuclei, and they're very viable. So that really allows everything to happen. In tropical climates, what's interesting, because you'd say, oh, well, then we shouldn't see these things in the tropics because the air is always humid. But it actually results in less transmission because literally it has to do with the sort of concentration of virus within a droplet or an aerosol is actually reduced. And it's important to remember, I'm jumping ahead of myself here, in tropical parts of the world, near the equator, you don't actually see this seasonality of viruses. They sort of circulate all during the year, but at very low levels because of the air tends to be quite humid. But humidity is the big thing. It has an ability to, when you get into low temperatures and low humidity, those all help facilitate the virus's viability, its ability to transmit. It affects your respiratory epithelium, the lining of your nose, your throat, and your lungs. And, hello. This is something that's been well described now too, is that when you have nice humid air that's hydrated, all the little things you can see at the top there, which are like bacteria and viruses and stuff, they tend to get flowed through because the epithelium, the cilia, which are the little hairs on the cells, are moving away. But when it's all dry, the mucus actually gets dried up. The epithelium, the cilia don't move things, and so now you're trapping pathogens right near the cell layer. And so the virus, in this case, can actually infect the cell much better because it's close by. So it's all about humidity. I think that's the real bottom line that we're trying to emphasize. And all the studies are really confirming that. So let's talk quickly about rhinoviruses, because this is really something we've all experienced. It's the most common cause of the common cold. As I said, we're peaking right now with all the kids at school. It's a fomite-transmitted virus. It's the one that you're going to get if you're not washing your hands and being careful about what you're touching and stuff, because it's really trying to infect this area around your nose and your eyes. So if you rub your eyes or go like this with your nose, like here I am doing it, basically that's how you introduce the virus in. It has some complications. Little kids can have a secondary otitis media as a cause of it, because it causes swelling in the eustachian tube, which equalizes pressure between your middle ear and your throat. And it can cause sinusitis. Most of us are familiar. As you get older, when you're young, rhinoviruses are not a big deal. The sort of runny-nosed kid playing around in the yard because he doesn't feel that sick. As you get older, rhinoviruses are a big pain in the neck. Because what actually happens is there's a higher incidence of sinusitis and bronchitis. And everyone here has had a cold, and then you're recovering from it. You're saying, oh, I think it's going away, but then you're like, and then you're coughing and coughing, and you're like, oh my God. So you eventually go see your doctor because you're like, I can't fix this cough. The treatment of that, believe it or not, is actually to give you anti-inflammatory things like a short course of either inhaled steroids or even a short course of prednisone, because that reduces the inflammation in the airways, which is what's making you cough. If you suffer from asthma, or if you have COPD, chronic obstructive lung disease, if you're an ex-smoker that smoked for many, many decades, this is the primary agent that actually causes exacerbations of those conditions. I know it's going to do that. And this is just, you don't have to pay. I don't want to turn you into total infectious disease nerds. This is a nerd slide. But what we know is that all of those viruses, particularly rhinos, and when they infect the epithelium, the lining of the respiratory tract, it leads to all of these things which result in airway hyperreactivity, which you can see in the lower left, the secretion, mucus, so you're coughing up sort of white or bland phlegm. You get edema in the airways. There's recruitment of inflammatory cells which cause the itis of the bronchitis, the inflammation, and it activates neural fibers which make you cough. That's where the cough is coming from. So actually, rhinos are the best at doing this. The other viruses can do it, but rhinos excel at this in particular. And it's really annoying because otherwise they're really not super dangerous viruses. Driving you crazy. So we already talked a little bit about kids getting annually maybe 6 to 8 colds a year. When you're a young adult, you may have them, especially if you're in your sort of reproductive part of your adulthood, and now you've got kids, and your kids are going to school, and they're bringing rhinoviruses, you're going to get them. And it's only when you become an old fart like me that the number of colds should actually kind of drop down a little bit. But then you get grandchildren, and they'll bring you a rhinovirus in and stuff like that. So, as I said, it peaks really right now. A little bit in the spring, but mostly the fall. Oh, that's one of my best jokes is coming up on this slide. You've all read it already. So sore throat's the most common manifestation, a little bit of runny nose, or sometimes a lot of runny nose. Fever's actually relatively uncommon. It's not like what I'm going to tell you about with influenza. And the usual duration of your symptoms, if you're relatively younger, is about 7 days, and then it disappears. And bronchitis, as I mentioned, is the biggest thing that we tend to see. So they cause some morbidity, and that's mostly in people who have underlying problems like asthma and COPD, but also people who are very severely immunosuppressed, people getting cancer, chemotherapy, and other things like that. For those of us who aren't in those categories, actually, it's really just a nasty, kind of annoying infection to have. There's lots of over-the-counter treatments for your symptoms. Most of them don't work, despite the Buckley's commercial where the person's going like, wah, and it goes, yeah, but it really works. It's a big business, though. I think it's like a $1 billion business, cold remedies that you can buy at things. And people do oftentimes seek treatment, particularly that long cough that goes afterwards. And the big problem there is that I have to convince my colleagues not to give antibiotics for that because antibiotics aren't going to work. They're against bacteria. But sometimes, people are like, no, this is different. It's definitely got to be a bacterial infection. And so ultimately they get some antibiotics, and that's not an appropriate thing to do. And that happens almost half the time when you go see a doctor with something, complaints like that. But the bottom line is what every medical student who I've taught this to for the last 35 years remembers, which is a typical cold, if cared for very carefully, lasts for a week. If not, it lasts 7 days. We don't do a lot of testing for these viruses. So, one of the things that happens after this is you guys are going to go, wow, I went to this talk and there's all these viruses. Like, can you test me for these viruses? So we do have testing available. It's very expensive. It's laboratory based in hospitals and stuff like that. And nowadays we're actually able to tell people, oh, you have a rhinovirus, or you have a human coronavirus OC43 or something like that. But that kind of knowledge isn't necessarily useful to you. For most of them we don't treat. But why we do them is because we're interested in the big bad guys. And this is my introduction to the big bad 3 guys. Many of you are familiar with that little device over there. It's a lateral flow test. The C stands for control and the T is the test. So the C is a positive control. So if that was there but the T was blank, you didn't have COVID. And you can get these tests for other viruses, for influenza and RSV too. If it's positive, then you got COVID, right, in those days. So the big bad 3, this is them. COVID-19 still at this point, influenza and RSV. That little graph is just to sort of show you the age-related risk of death from respiratory diseases, and it includes influenza and COVID-19 as well as some other viruses. And you can see that it's the extremes of age. To the very far left are young people, kids, little infants and stuff, and at the other end are older people. So just in terms of global virus-related deaths, these guys actually sit somewhere right in the middle. Influenza and RSV, it's an older graph, but you can see amongst all these viruses, some of the ones like HIV and hepatitis B still account for more deaths per year, but influenza and RSV ain't far behind. This is just to remind you about the dates when everything happened back in late. I was already freaking out on like January 1st, 2020, because the reports were coming out of China at that point, and I'm like, oh, crap. I just wanted to ease myself into retirement, and it wasn't going to happen. But by January 30th, a month later, it was declared a public health emergency of international concern. The pandemic was actually declared on March 11th of that year, and that's when everything kind of shut down. And many of you hopefully will recall to some degree, because some of the things, when you get bad things, you try to forget them. But people were dying, and healthcare workers were dying in New York City, in Italy, in many other jurisdictions around the world. And yeah, it was pretty scary. And they had like refrigerated trucks out in hospital parking lots because the morgues just didn't have ability to have them. So whenever anybody goes, oh yeah, well, COVID wasn't a big deal, they're just forgetting about the early few months in 2020 that we were dealing with. And eventually it was declared over, at least the public health emergency was declared over in 2023. So we are in the resolving phase of the pandemic. I think that's my next slide. Let me see. Yeah. So I like to show this slide because for people who think that, we didn't have to rush into all of those measures and everything else. I'm going to show you. This is United States of America, starting in February of 2020. Hopefully you guys can see the map. I don't see the states as well, but I guess it'll show up in a sec. Ooh, hey. Uh-oh, this is a Windows computer. There we go. Thanks, Windows computer. That was actually a graphic. It was going to show you 18 months of COVID-19 in the States. And it started, you can see, up in Washington and then in Southern California. And then, yeah, I think it might be, there we go. So here we're taking off now. This is how fast it went. Thank you. Thanks, Kristen. So we're now into April. And this is, remember, things are shut down at this point, even in the States. And now we're getting into the summer of 2020. Some of the areas that are going to light up here, if you know anything about voting patterns in the United States, you will see how it maps out. That was related to a motorcycle club gathering in North Dakota. Now we're getting into the winter of 2020. Now we're getting the vaccine. And this is the effect of the vaccine. You can see it just like sort of vanished, at least was low level at this point. But then at this point, people are saying, oh, well, it was nothing. You're impacting on my freedom. There's a thing called psychological reactance. When you tell somebody they can't do something, they want to do the opposite. So this is what happens now in the summer of 2021. It just blossoms again. And again, if you look at the pattern of where this lights up, and then this is in October of 2021. So yeah, that's what a pandemic looks like if you want to map it out on a map. So I wish I had a Canadian map, but we just don't have sophisticated map making here in Canada to do that. These are the waves in Canada, just to remind everybody. They were related to all these different variants. We're now facing XFG, which is the new variant that's emerging into the fall of this year, and we're going to see where that goes. Fortunately, in Canada, lots of people are still very careful and appropriate. A lot of us are vaccinated, can remain vaccinated, and that's really, really important. The Americans are going to face what they're facing because for them, individual freedom is more important than their duty to their fellow citizens around them and stuff, and so that's where you end up with all this other kind of stuff. But that's a little schematic of a coronavirus. It's called coronavirus because it has this little crown around it, a corona. And these are actually the electromicrographs you see on the right-hand side. Those are actually the first EM shots of SARS-CoV-2, the virus that causes COVID-19. And they were published in early 2020 by a group who at that point. I like to put this one up because it's really important to remember, because at the time, some of you again will recall, people said, well, it's no worse than the flu. I mean, flu kills people, so why are we so worried about this? What you see in blue there is the influenza case fatality rate, and what you see in red is the COVID-19 case fatality rate. It was 10 times that of influenza. So if anybody was telling you it was the same as the flu, they were gaslighting you. Right? And they were doing that for oftentimes ideological reasons more than anything else, because they wanted to pursue an idea that you shouldn't do anything about this. We're shutting down society. We can't do that. I gotta make me bucks. So it was a fad. Nowadays, with the vaccine, with changes in the virulence of the virus, it has become a little bit more like influenza in terms of the case fatality rate, the likelihood of dying if you would get a case of it. This is just an estimate of the worldwide excess deaths, and I kind of think it's weird, like this doesn't show up as well on these slides, but at least the two dark ones did. So the central estimate for the world was about 25 to 27 million people died of COVID-19. For those of you familiar with the famous quoted numbers about the influenza pandemic, it was about 20 to 40 million during the Spanish flu epidemic of 1918, 1919. So this was very close. The higher estimate actually puts it up in that 35 million range. What you see in the bottom line are just confirmed deaths. And people were dying so quickly that oftentimes people said, oh, well, they just had a bad heart. Yeah, they got COVID-19, but it was their heart. No, it was the COVID-19 because they had a bad heart. It kind of polished everything off. I put this up because it's a very Canadian slide. This is a North Atlantic right whale. And many of you know they're endangered because of shipping on the East Coast. And this nice big whale is saying, I need physical distancing. So this is sort of a cute joke on the idea of what's going on. So just to remind you that COVID-19 is a virus that inhalation plays a big role, and short-range aerosols are probably the main issue. So these are very small particles that are emitted. I'll just say that you need close proximity to get COVID. You need to either be in direct contact, you need to be close enough that the environment's being contaminated that you're now touching, because you can spread it through fomite transmission. But we do believe that the short-range aerosols probably played the major role. And that's just to point out that longer-range aerosols were implicated in the transmission of COVID, but it was under very particular circumstances. And that's very different from measles, where measles long-range aerosols actually are a major, major player in the transmission of measles, which is the classic airborne infection. Public health measures worked. On the bottom of this graph, you can see that hand washing reduced the relative risk by 50%, mask wearing reduced it by about 60%, and physical distancing actually helped as well. So those were all things that were recommended and can be done, and they did result in a reduction in transmission of COVID back in the early days. This is just very quickly I want to skip over this. I was telling you that when COVID came along, all these other viruses, rhinos, influenza, other human coronaviruses, and RSV, metapneumovirus, and parainfluenza, in those red arrows are all during the most intense years of the pandemic, that very first year. And they literally disappeared. So why did they disappear? Well, there was viral interference, I already told you that. But the other reason they disappeared is we did things to prevent the transmission of viruses. We were all hanging out ourselves. We had our little groups that we hung out with. You wore a mask when you went out. You were physically distancing from people. And, look at influenza. I mean, that's a precipitous drop. And even in the second year of the pandemic, it was still down quite a bit. So, COVID had an impact on these other viruses for sure. So how do vaccines work? I always use this slide because Lego blocks, even a little kid understands Lego blocks. If you were unvaccinated, you could get severe disease. If you were vaccinated, you were likely at the most to get a mild or moderate course, and a lot of people had asymptomatic infections afterwards. So vaccines really worked for COVID, and we're still advocating for them. This was a cool slide. It was made up by a guy who works at the Financial Times. And what they actually showed is that if you got vaccinated, so if you're not vaccinated, you're a red dot. If you got vaccinated, your likelihood of dying fell where that blue arrow was. So if you were 80 years old and vaccinated and you had the vaccine, your mortality rate from COVID was like that of a 50-year-old, which we don't consider to be old. So all of you who are 50 or younger, you're young. I passed that a while ago. And this is a logarithmic scale that you're seeing here, right? So just be careful. It's not a linear one. It's a logarithmic scale. So it's quite a dramatic drop. And vaccines really did prove to work quite well. So where is it going this fall? Just to finish off with COVID-19. Come on. There we go. So this is a trending graph just to sort of show you things from the beginning of 2024 on the far left here. Blue is influenza again, red is COVID, and green is RSV. And you can see the rise. As soon as flu goes up, COVID goes down. But right now, there is a projection that COVID's probably going to have a bit of a fall wave. And it may be tempered if the influenza wave, which we're also predicting might be a bit early. If influenza gets up, it's going to knock COVID out. And of course, a lot of it's going to depend on people maintaining important practices and including getting vaccinated and stuff. So this is just a graph that the province produces, which looks at this is genomic analysis. Everything you see in purple is the new XFG recombinant variant of SARS-CoV-2. JN1 is the old green stuff there, and it's pretty well get knocked out. So viruses evolve, and they kind of then swoop out the other ones. The first original virus that caused COVID-19 is probably extinct, because it's gone through so many changes and stuff. It hasn't established itself, and these other viruses have pushed it out. So that's where we're going right now. So let's talk about the big bad one, influenza. I think influenza is still the king of all the respiratory viruses, if you had a hierarchy. And lo and behold, apparently in the United States, they like hierarchies nowadays. So I always put this slide up for medical, because people go, oh, I had a cold or the flu, something like that. No. If Thomas the Tank Engine, a little toy Thomas Tank Engine is common cold. A full-size locomotive is influenza. And when you get influenza, you know you've had influenza. So it's because flu is such a common thing to sort of throw out, right? But there's a huge difference in the two infections in terms of how severe they are. Lots of burden from influenza, over 1 billion infections every year. Lots of severe illnesses. Around the world, it probably leads to about 500,000 deaths every year. Here in Canada, leads to, we think, somewhere around 3,000 to 4,000 deaths. Lots of hospital stays. So, people who run hospitals, like lovely Julie Caffin here, you know, they don't want to see this because they got a lot of other things to do in the hospital, and having to have people who are like getting sick from something that is essentially, I'll say, at least partially preventable in terms of hospitalization. Again, influenza is very famous for picking on the extremes of age. You can see the age groups here. The young and the older members of our population are the ones that are most affected by, and this is a graph that shows hospitalizations. So if you're in the middle group, middle-aged or a younger adult, or maybe an adolescent or something, yeah, you're probably not going to have a really hard time dealing with flu, other than you're going to realize how bad a disease it is. And kids are very affected by influenza B. And then you're going to go, what the heck is influenza B? And the answer is coming up on the next slide. There are actually 3 kinds of influenza virus, A, B, and C. A is the one we really worry about. That's what causes all the real big bad things and causes pandemics, like in 2009 when we had the so-called Mexican flu. I won't tell you that it was actually the California flu, but the Mexicans got blamed because the Americans can never take blame for anything. My apologies to any Americans in the audience. My sister's an American. Influenza B can cause moderate to severe disease, mostly in children. Kids don't like influenza B. Adults do okay with influenza B. And there is an influenza C, and I hate to even mention it because it's really just a kind of a virus that causes a mild disease. Who cares? It's a little bit like getting a rhinovirus or something like that. And just a reminder, because we're here by the riverside, like influenza, the natural reservoir for it is aquatic birds. So all those lovely mallards, mergansers, and all those other ducks and geese and things out there, yeah, they all carry influenza virus. Now, most of the viruses they're carrying may do them in, but they don't transmit to us. But that's where all influenza viruses come from, is from aquatic bird species around the world. And that's why it can spread, right? It follows migratory pathways of waterfowl. In the world, basically to remember that it causes seasonal epidemics all the time. We're about to enter into that from October to April, May. In the southern hemisphere, they've just come out of it. Theirs is May to September. And as I mentioned, in the equatorial regions, it sort of circulates all the time. These are just a graph showing the peak of the season. The numbers you see at the bottom of that graph there are the weeks of the year. So 1 is the beginning of January. And you can see that it can start as early as sort of November, typically in Canada, and can extend all the way out to around March to April. With peaks that are occurring very frequently. Trying to predict when that's going to happen is actually a fool's game, because sometimes I've done it and then people go, wow, you were right, it was really that. And then the next year I try to make them forget that I was completely wrong, because then it didn't happen the way I thought it was going to happen. Typically, peaks peaks at about 4 to 6 weeks after onset, lasts for about and disappears. Influenza A and B can cause different things each year. The little pie graph at the bottom is basically showing you the 2 main A's, H1N1 and H3N2, and B in blue is the influenza B. And each year, we can't sometimes predict, is it going to be mostly A, mostly B, mostly H3N2, and a little bit of H1N1, or is it going to be mostly H1N1? It depends a lot on what the virus does itself and how well we're protecting people. This is just a graph. This is actually from the New York Times back in 1919. And it actually shows you the mortality in London, Paris, and Berlin in late 2018 and going in 2019 from Spanish flu. And remember, in those days, they couldn't even track things particularly well, but it's like, those were huge numbers. Since then, we've had minor pandemics. The Asian flu, the Hong Kong flu, the Russian flu, the Mexican flu. The Spanish flu, by the way, was a real bad marker. Do you know where the Spanish flu started? That's right. Actually, specifically, it was either Oklahoma or Kansas. So, but again, Americans never like to take blame for things like that because it's always somebody else's fault. Oh, come on. There we go. This is just a graph, and then you can see the Spanish flu prediction of deaths. It was, close to 40 million. Some people said it may have been even higher just because we didn't track deaths all around the world. If you were living in Africa and other parts of the continent or other parts of the world where there was no tracking of data, then you may have had deaths and not know it. The other ones have been relatively mild. including the swine flu / Mexican flu in 2009. And that was actually interesting because it was so close to the Spanish flu in terms of its antigenic makeup that if you were older during 2009, you actually did way better than younger people. And that has to do with a thing that's really cool. We call it original antigenic sin. And it has to do with which of the influenza A viruses you were first infected with when you were a child. And that's the one that you develop your most robust immunity to. So people like me, I'm a boomer, my first influenza infection was probably H1N1, which is what 2009 was. But a lot of young people, really anybody born since after about the late 1970s, they were H3N2 original antigenic sin. So when this Mexican flu came along in 2009, they were a little bit more susceptible to it. So we didn't actually see as many deaths because a lot of older people had some already immunity from their original antigenic sin. There's something you can take home and Google it, original antigenic sin. You'll probably come up with something very bad on your computer. So influenza is really scary because it's a funny looking virus. You can see the schematic on the left here. The little stuff in the middle are pieces of its genomic structure, its RNA. And in the influenza virus, it's not just in one small circle, it's actually 8 segments. And so that allows when the virus reproduces for all kinds of mistakes to be made because little structures cross over. And so this virus, influenza virus, tends to mutate like crazy, which is why every year we have to have a new vaccine. And if it does a little bit of change, it's called antigenic drift, which ain't so bad. That's the one that causes the vaccine changes. If it changes a lot and quickly, or it recombines with a new pig influenza or duck influenza, then you get antigenic shift, and that leads to pandemics. I know, I'm giving you like way too much nerdy infectious disease stuff here. I apologize. There's a great vaccine for influenza. It's getting better all the time. We now have ones that are mostly cell culture, not egg-based. So if you did have an egg allergy, you can get the cell culture one. By the way, if you had an egg allergy, you could still get the egg-based one. The likelihood of a bad allergic reaction was actually quite small. There's a high-dose vaccine now, so anybody over 65 or older, or anybody with some underlying medical conditions, you should get the high-dose influenza vaccine, not the regular dose. The regular dose is for healthy, younger people and stuff. And we actually have vaccines that work in smaller children, which oftentimes have to be given, if they've never had the vaccine before, in 2 different doses. Its efficacy is not 100%, and that's really what bugs everybody, but it actually is very effective at reducing the severity of the influenza you get, and you're less likely to end up in hospital. And that's probably the most important factor. Less you can feel like crap for 3 or 4 or 5 days as you go through the peak of the illness. But if you don't end up having to go into hospital with all the other things that are involved in it, then it's better for you. It's better for the other people who need the hospital beds. It's better for Julie because she can keep her budget in shape and not have to worry about crazy surges in things that are going on. How is vaccine coverage in Canada? This is some data from now 2 years out of date. But you can see in older people, we're doing pretty good. About 70% of people over the age of 65 get their flu shot. Not so good in the middle years and as much. And if you look at all adults over 18, it's about half of that as well. It's down about 40% or so. So I do encourage people to get their flu shot. It is really useful. It's very short-term pain for long-term gain. And this is just a table that shows the reactions to the flu vaccine compared to getting something that you thought was the flu vaccine, was actually the famous placebo, also called placebo. But in fact, other than the arm soreness, which yes, I've had my flu shot every year, and yeah, my arm gets pretty sore for a day or two. It's not good. But serious side effects don't happen. It's a killed virus vaccine. You cannot get the flu from the shot. It's a killed virus vaccine. And we're getting better. We're starting to get close to maybe a universal flu vaccine in the years to come. So finish off quickly with RSV. So RSV is probably not familiar to some of you, although any of you who've had a small child who had an RSV infection when they were young will remember this well. So this is a virus that we always used to really worry about with little kids. Because if a small child under the age of 1 year gets RSV, and it's a seasonal virus, I showed you the graph already, they can develop a very severe condition called bronchiolitis, which is essentially a fancy term for an infantile pneumonia. And they can die from that. And the good news is we've got lots of really good strategies now to prevent that from happening. But what we've been finding out of late is that actually adults can get RSV, and it produces a similar complication hospitalization profile as influenza. So it would be really great to have an RSV vaccine because we'd like to give older adults a vaccine that also prevents them from hospitalization and serious illness. So it's after influenza and SARS-CoV-2, it's the most common serious one. There's actually 2 subtypes, which is, again, infectious disease nerd stuff. You don't really need to know that. It is, like all respiratory viruses, contagious for about a period of anywhere from 3 to 8 days after following infection. 3 days is the usual kind of incubation period. And the one big problem with this virus is it doesn't cause long-term immunity. So I'm old enough that I actually had measles. And that's because there wasn't a measles vaccine that was effective when I was a kid, not because my mom was an anti-vaxxer. My mom was very interested in having us vaccinated. In fact, I even had 3 smallpox vaccines. So if smallpox ever ravages the world again, some of you are going to die, but I'm not going to because I've had 3 smallpox vaccines. But anyways, it doesn't confer immunity. So if you had RSV, a few years later, you can get RSV again. So that's the bit of the challenge in prevention. Little kids, that's a little X-ray with bronchiolitis there, very bad. Bronchiolitis are the little tiny, bronchioles are like little tiny bronchi. They're the little parts of the lung, and little kids, those are really delicate, and if the infection gets into that area of the lung, they get seriously ill. These children require ventilation, and some of them die from this if they develop it. In adults, what we're seeing is that if you look at hospitalized patients and you compare RSV and influenza, actually RSV has longer lengths of stay, more common ICU admissions, but the mortality rate's about the same, but that's pretty high, like 1 in 10 people. And it accounts for about somewhere around 10% of COPD and pneumonia admissions now that we're multiplex testing people that come into the hospital, asthma admissions, and heart failure admissions. And by the way, influenza, one of its main problems is heart failure issues like heart attacks and heart failure. It exacerbates. So here's the good news part of RSV. We got great stuff now. We've got 2 different vaccines, one of which you can actually give to pregnant women who is expecting to deliver their baby in winter. And when you give that vaccine to the mom, she makes antibodies, she passes them to the child in utero, so that when the child's born, they have what we call passive immunity. Their maternal antibodies are there, so if they were to unfortunately get RSV, they would have a very attenuated illness. They wouldn't get maybe colitis or anything like that. If the mother hasn't been vaccinated, and a child is born, say, in the fall, and now they're entering into the winter at the age of 1, 2, 3 months, you can give them this monoclonal antibody, called nirsevimab, and there's another one called sesvirimab, and that's another form of passive immunity. And this stuff is amazing. You give it to a child, it lasts about 3 to 6 months, so it'll get them through the winter. And this strategy has now been used for a couple of years, and it's dramatically reduced RSV hospitalizations and deaths from RSV in both adults and in children. If you are an adult in Ontario and you're over age 70, you can get this vaccine. If you are not over age 70, but over like 50 years old or so, but you have an underlying medical condition, you can also get the vaccine. Really cool about this vaccine, seems to last at least 2 years, may last 3 years, which is cool, right? That means they don't have to get a shot every fall or winter. So this is just a graph to sort of show you all these viruses we've been talking about. Again, nirsevimab is really not a treatment. I called it in that treatment column because it's a passive immunity. It's really, in essence, a kind of vaccine, but it's where you're just given the antibodies, much like your mom gave you the antibodies from the vaccine. Of course, for flu, we have oseltamivir and amivir, and there's a new anti-flu drug called baloxavir that's now going to be marketed in Canada. It's a 1-tablet deal. So oseltamivir, anybody's ever taking Tamiflu, it's called the trade name. It's a 7-day course. But baloxavir, which is called Xofluza, oh my, seriously. It has an X in it, so that must mean it's like really special. They play with your minds, the pharmaceutical firms, I'll tell you. Anyway, Xofluza is just a 1-shot deal. And then, of course, we still have Paxlovid and remdesivir for COVID-19, and of course, we have vaccines for COVID-19 too. Unfortunately, for all these other viruses, we got nothing. But fortunately, morbidity and mortality from them is not particularly bad. We can do this. This is the most important slide. So people always say, well, what can I do to prevent myself from getting a viral respiratory tract infection? Number one thing, if you're still working, is don't go to work if you're sick. And you know, we live in a culture where going to work when you're sick was considered like, oh yeah, you came in, yeah, you're good, man. You didn't have to do your work because you came in. Yeah, I'm here, I'll help out, you know, and you're like spitting and coughing. So now everybody's getting infected that came into work with you. So we tell people to stay at home. And it's not hard to stay at home if you have influenza, probably when you have COVID and with older people with RSV. But the other viruses produce a milder illness, like your runny nose, your sore throat, but you don't really feel terrible, like you're not achy. So, oh, maybe I'll come in, because if my work partner was sick, I would want them to come in too, so I don't have to do as much work. So we have to get away from that culture. Hand hygiene is still important. One of the things that bothered me a bit about COVID-19 is there was so much emphasis on masking that I saw on social media people going, oh, don't worry about washing your hands. Washing your hands is not important. Clearly, they never had Salmonella, Shigella, Campylobacter, and they didn't have a lot of rhinovirus infections or that, because you have to wash your hands. That's another mode of transmission. Wearing a mask, very important. And there's mask wearing for you. Wear a mask or a respirator in crowded situations, especially when activity is high in the community. Cover your cough. You're supposed to cough into your elbow, not into your hands, because then you go and touch a doorknob. And, you know, practice a bit of physical distancing and stuff. I've managed to maintain a reasonable distance so far without affecting the two very nice ladies in the front row here. And then lastly, get vaccinated. Vaccines work. You know, we're into a very dark time where vaccines are now suddenly being implicated as causing all the bad things in the world. Some of these people clearly are not old enough to remember polio, diphtheria, kids dying of whooping cough. Like, you know, I mean, those were deadly diseases. Vaccines just made them disappear. And the problem when they disappear is they disappear out of the minds of people. And they go, oh, yeah, polio. Yeah, I think I knew an old neighbor who had that, but I haven't seen anybody with polio. Why do we need vaccination? Because right now in the St. Lawrence River, there's a shitload of polio virus, pardon the pun, by the way, because it's an enterovirus, so actually it's spread through the fecal-oral route. So swimming in fresh water in Canada got you polio. If those of you who are old enough to remember, polio peaked in the late spring into the summer when kids were out swimming in lakes and having a good time. That's how you got polio. That's how Franklin Delano Roosevelt got polio, although I think there's a lot of question of whether he actually had polio. So viral respiratory tract diseases occur in all age groups, but they're most deadly at the extremes of age. In Canada, it's chiefly a seasonal threat, at least with the big bad three guys. They are linked to exacerbations of some of the diseases we're familiar with, like asthma and COPD. It's important to recognize them to try and prevent unnecessary antibiotic use, but that's mostly I pitch at my physician colleagues, because they're the ones that are going to be doing the prescriptions. Wear masks, wash your hands, and they'll help reduce transmission. And remember that there's vaccines and some antiviral therapy for some of the big bad ones, maybe with some evolution into something eventually into the future in that. So I apologize for going on forever and ever, but as you can see, I'm too nerdy. And yes, I like squirrels. Thank you.
Thank you so much. That was amazing. I'm reeling right now, but tomorrow they'll all sink in really well. Thank you very much. This is a time we're going to ask the audience if you have questions. We're giving you a card, and if you want to write it down and you don't want to ask yourself, we can collect the card and get Dr. Evans to answer the question. But if you have questions, we've got a microphone that we'll hand to you. We are recording this, so there's not a likelihood that you'll be on the film, but you might be. I just wanted to make sure you're aware of that, particularly when you ask your question. But please do ask any questions. It's a great thing that we have Dr. Evans here, and he's not shy of answering any type of question that you might have. He can't diagnose you, but he can certainly answer any questions that you have. So we've got, who has the microphone? So Sue here has the microphone. So again, please talk into the microphone because it is being recorded, and that's the only way we can capture your question. Thank you.
When's the best time to get the RSV vaccine?
If you haven't had it, yeah, it's around the same time you get your flu shot. So it's the fall. We're again remembering that RSV, influenza, and now a little bit, I think COVID is certainly, as it moves to endemicity, it's moving towards being a seasonal virus. So you can get it at the same time. And you can get your flu shot and your COVID shot at the same time. Lots and lots of data that it's perfectly safe to get them together. Yeah, one arm might be sore and the other arm might be sore, but it's short term. RSV, if you're eligible, it is covered by the province. If you're not, it's a bit of an expensive vaccine. So, you know, if you're a very healthy 58-year-old, then unfortunately you'd have to pay for it yourself because you might fall in the category that it's offered for. Flu shots and COVID shots are still going to be covered in Canada, unlike in that country that's just across the river from here. Yeah. So yeah, get them in the fall. And if you had the RSV one, it's going to last you for 2, maybe 3 years.
Okay, I have a question. I had COVID twice last year,
Oh, yeah.
in October and December. Do I have enough immunity that I don't need a vaccine?
Well, if you had it last year, you probably had a JN1 virus. And the new vaccine is actually tailored more to the evolution of that JN1 variant. It's not the XFG, it's actually called LP81, but it's probably going to give you better, better protection. If you get a natural COVID infection, immunity does wane a little bit. And one of the interesting, fascinating things I'll bore you to tears with for 2 seconds. When I was a young guy, and I was an ID fellow at the University of Calgary, my research work was on coronavirus. And I thought, why am I studying this? Coronaviruses are never going to cause anything really important. And lo and behold, it came along. And one of the problems with coronaviruses is they don't leave you with long-lasting immunity, much like RSV. So I think if it's been a year, it sounds like it's been about 9 or 10 months since your last infection, then getting the vaccine is probably certainly a reasonable thing to do. Because that immunity probably has worn off a little bit. And you have a few more gray hairs than me, but our immune systems as we get older just don't stack up like they do for some of my younger colleagues that are sitting in the audience there.
Thank you.
You're welcome.
Hello.
Hi.
First of all, thank you for that wonderful presentation. I have to say that I found it very refreshing. I recently retired from working in infection control in Ottawa.
Oh, yeah.
I worked at Queensway Carleton Hospital.
Oh, yeah.
So this is my first time ever coming to this area and sort of refreshing that history in my mind, and I pretty much feel like I have PTSD from COVID-19, but that's besides the point. My question for you is, with RSV, if a child has had it and they ended up being hospitalized, and that was approximately 2 years ago, and I'm speaking to my granddaughter, if they're more likely to get RSV within 3 years, similar to the vaccination?
The thing about RSV in children is that under the age of 1 year, it's where it's the most deadly. Okay. Do children get RSV when they're 2, 3, 4, or 5 years old? Yes, but it's at that point, especially with a prior infection, it's probably just a normal upper respiratory tract infection. It doesn't carry the same gravity and worry about the complications like bronchiolitis. So, and again, recognizing this, because we've studied it, RSV has been well studied in children. It's that young age group that we're mostly worried about. Once kids get RSV as they're toddlers or approaching the age of 10 and then becoming adolescents and youth, RSV is probably a pretty reasonably handled virus by most people. But now we recognize that if you're older, though, it comes back to being a lot more of a problem.
Okay, thank you.
You're welcome. Were you an infection control practitioner?
Yes, I was.
Yeah, there's a few of them right behind you there too, by the way. Dana and Danielle from the hospital.
You look familiar.
Yeah, you guys can commiserate.
Okay.
Oh, there's one.
Is the proper COVID vaccine available now for the upcoming season?
Both the Moderna and Pfizer vaccines have now been licensed by Health Canada. Moderna, in fact, has 2 factories in Canada. So if you get your Moderna COVID vaccine, it's going to be a Canadian-made one. They're supposed to be available near the beginning of October, but now you're subject to the vagaries of capitalism and shipping and all the other things that go on. But I know that that's the hope and expectation, much like the flu vaccine, that it'll be available by early October, and then people can get their shot when they go for it at a pharmacy or at your doctor's office, or even, dare I say, sometimes public health will have vaccine clinics. But I think nowadays they kind of want to farm it out there. So it should be available very soon, because we're almost at the end of September.
Thank you.
I always have a way of having a long-winded answer to a very short question. Got one here, and then you're...
Thank you. I understand that while I was at the washroom, you talked about the RSV vaccination, and I went looking at it today, and they didn't say that seniors could get it free. How do you do that?
You have to be over age 70. So
Oh,
you don't have to reveal any state secrets right now.
Well, I'm a year short.
If you're under age 70 though, and you have a pre-existing heart or lung condition or something else like you take immunosuppressive meds for dermatological, rheumatological, or gastroenterological things, a pitch can be made for you to receive it, and at least to have it covered is more the issue. Everybody can get the RSV vaccine, but unless you get that, you fall into one of those categories, the province won't cover it, and you have to buy it out of
It is a provincial one, though, is it?
and it's pricey. What?
It is a provincial one, though?
Yeah, so
Is it
those are the provincial criteria for the administration of the RSV vaccine.
Because it's very expensive.
It is really, yeah. I was just mentioning that. It's very pricey. It's like, I think, $250 or $300.
Yeah, it was a little bit of a shock.
Yeah. Well, it's always also one of those crazy things like, and I mean, everybody's of different means, but, a vaccine is going to last you for 3 years, like, maybe popping out the Spondulix for it isn't such a bad thing, but I agree. I mean, it's not that everybody has a disposable income to be able to do.
Yes, that's true.
If that impacts your grocery bill, yeah, that's not a really wise strategy. Yeah, agreed.
Thank you.
You're welcome.
Hello. Thank you for being here.
Hold it a little bit closer to your mouth.
Over 25 years ago, I had bronchitis for 3 months. And my doctor at that time also believed in some alternative medicines. And he gave me a prescription, a 6-day plan, which included 1 vitamin C, 1,200, 2 garlic oil tabs, 3 garlic oil tabs, and 2 Lactobacillus acidophilus, and 1 tablespoon of lemon juice. And he told me to take that anytime I feel a cold coming on or a flu. And I've been doing that for over 25 years, and I don't get sick. I introduced it to my husband 9 years ago, and he doesn't get sick. What do you think of that?
So in medicine, we would call that an anecdote. And it may be very much related to other factors that you're not aware of. For instance, if the two of you live and you're not exposed to lots of other people around you who would have it, like young children, little babies and stuff. And I also am very prominent that the plural of anecdote is anecdotes, not evidence. So does that work? Yeah, if it does, but I have no idea what the mechanism would be. Vitamin C was poo-pooed, as you know, many years ago. Linus Pauling, the famous Nobel laureate, promoted vitamin C as a means of preventing common colds and stuff like that. There has been studies done to that, and it doesn't work. But you're mentioning that you've got a probiotic in Bacillus acidophilus or Lactobacillus acidophilus, and you said something about garlic oil or something like that?
3 garlic oil tablets.
Oh, yeah.
Yeah.
Well, the other thing, and I just mean this in just because it's a good chance. It was like a literally opening line. One of the ways to keep people away from you is take oil of garlic oil, and then they won't come close to you. And then you're like, hey, that's why it worked, because nobody's coming close. And not only that, you probably haven't been bitten by a vampire in the last little while either. So I'm sorry, that's just a joke. I'm just trying to think of it. I don't if it works for you, it's great. I don't know why it would work. I know of no science that would support that, but.
With respect to the pneumococcal virus, or it's bacterial?
Oh, pneumococcus?
Yeah.
That's a bacteria, yeah.
That's bacterial. Can I ask a question about it?
Sure, yeah.
Is it recommended that you should have like the Prevnar, the Pneumovax, every 10 years? Or once you've had it, is that
Yeah, so the Pneumovax is becoming obsolete. It's what we call a polysaccharide vaccine. It didn't contain a conjugate attached to it. Prevnar and variants like Prevnar are what we call conjugate vaccines. And the reason it's different is that when you get a Prevnar vaccine or any of the conjugate pneumococcal vaccines, it induces a memory B cell and T cell response. So you get the vaccination, and then your memory cells remember it, so that it actually, we don't know how long it lasts in adults. It may last out for 1 or 2 decades. Pneumovax probably needed re-administering every 5 years, and it wasn't very effective. It's being taken off the market now. So,
so there isn't a booster right now suggested for the Prevnar.
But you really, if you've had your Prevnar vaccine, I would say there's no indication at the moment that you need to go for another shot.
Okay.
Yeah. And I do actually encourage people to get, if you're older, pneumococcus, the Streptococcus pneumoniae, that is the #1 bacterial cause of pneumonia in older adults. And it can be quite deadly. And what the conjugate pneumococcal vaccines is, they reduce hospitalization, they reduce death. Right. And in fact, they actually reduce infection, which Pneumovax never did. And so it is worthwhile. And again, if you are over the age of 65 in the province of Ontario, Prevnar is covered at your doctor's office.
Okay, thank you.
And yeah, it really hurts when you get it in your arm. I know I had it. But that's okay. A couple of days of a sore arm. I live with pain nowadays every morning when I get up. Is that it? Great. Well, thank you again very much. I really appreciate being invited. Thanks a lot.
Okay, well, thank you everyone for coming, and thank you again to Dr. Evans. We know how terribly busy you are just by the introduction we gave, for coming here to Brockville to talk to us, and there's a small token of our appreciation.
Oh, thank you.
Thank you. And thank you to everyone. And I think Trish wants to give a plug for the next one.
Yes, actually, the next one's going to be in January, the 21st, I think, and it's going to be on mental health. We've heard that a lot through the last MEDtalks, is that folks want to talk a little bit more about mental health, so we'll have a really good panel for that. So please plan to join us again Wednesday, January the 21st, here at the amazing Aquatarium. Also, when you came in, you were also given a little bit of a survey there. If you wouldn't mind filling that out, and that really helps us for each one of the sessions. And again, Dr. Evans was amazing, and we're very lucky to have him come into our community. So thank you again.